afternoon or evening, depending on where you are. And thank you for joining our webinar today. We have Dr. Hernandez presenting moving hepatic regional therapy beyond FUDR. And Jonathan's a very good friend of mine for many, many years. He is currently the head of metastasis biology section at the National Cancer Institute at the National Institutes of Health. He's also the chief surgical oncology division section, and he's published over 100 peer-reviewed publications. But more than that, he's a great doctor. And like I said, he was a fellow at Memorial for many years, and we've just maintained this awesome friendship. So I'm really grateful for him for presenting today. And I'll turn it over to you.
Well, thank you, Jenny. As you know, I could never say no to you. So here I am. And so what I thought, let me share my slides. And please tell me if this is working out okay. Let's see, can you see them?
Yeah.
You see my slide okay?
Yep.
The first slide looks like a liver histology immunofluorescence slide.
Yep.
Okay. And things are advancing okay? Yes?
Now it is. Yep. You're good.
Okay, cool, thanks. So I thought I'd talk about moving hepatic regional therapy beyond FLOXURITY and FUDR. And so, I'm at the National Cancer Institute, so our task is really to do something new and bring something new to patients. And so I'd like hepatic artery infusion pump therapy, but it's got to move forward. It cannot stay the same. Nothing ever can stay the same. And so what I thought I'd talk to you about is my efforts to do that. And so I'll just begin. And so I'll talk a bit about hepatic artery infusion pump. I know somebody has talked to you about this before. I can't remember if it was Mike or who exactly it was, but I'll go into brief background. And then I'll talk about mitigating toxicity. I'll talk about expanding therapeutic agents, and I'll end very briefly talking about new patient populations. So hepatic artery infusion pump therapy, although it's being done increasingly across the country, there are trials ongoing. It is not new. No one should delude themselves into believing they're doing something new. I mean, this dates really back. The first time anyone did arterial chemotherapy was in the 1950s. You can see this nice old picture of an external pump. And so this concept of pump has been around quite some time. And in 1978, I know that year was 45 years ago because that's the year I was born, we got FLOXURITY. And so, and then it really hasn't changed a whole lot as far as drug delivery. Pumps got developed, but we really have not evolved the way systemic chemotherapy has. And, the pump that everybody uses today looks like this. For a while, we were using Medtronic, but the Intera, which is previously the Codman pump, looks like this. It works on this bellow system where at body temperature, it slowly infuses medicine over a period of time. So it's got it's not like a bolus thing. Of course, you get to have medicine over a prolonged period of time. Again, but we're still giving only one therapy. It looks like this. It's like I always describe it to people as a hockey puck sitting under their skin. The Intera pump has a bit of a nipple on it, so you can feel it. It's a little easier than the Medtronic pump, which is sort of flat. But these are really just pumps. They shouldn't be thought of as anything more than that. And so what is this? This is not a trivial undertaking. It's not like a metaphor. You have to do a fair amount of work in the operating room to get this correct. I usually make videos for people, and so this is
okay. So this is the bile duct. Again, you can be right on this because the blood vessels run in the wall. Now this person has a replaced right hepatic artery, which one can see here, wrapped in this blue string here. And then this big vein looking thing here is the portal vein. And so this runs posterior.
Sure, video.
Okay, so this.
Well, we'll just skip through this. I make this for the residents. But anyways, this is the hepatic artery. So you got to stick that catheter right in here. And at the end, this is sort of what it looks like. So it's not just like putting in a metaphor. You have to do a fair amount of work. And again, we're sort of stuck with and it goes into the gastroduodenal artery. So blood flow comes up here through the common hepatic artery and then goes up into the proper hepatic artery. So the chemotherapy gets delivered here and gets taken up into the liver. Important part about this is the artery supplies the tumor, but it also supplies the bile ducts. That's going to become important. And why do we do all of this? Well, Nancy Kemeny, and this is over almost 20 years old now, ran this trial where it was compared to first-line chemotherapy, and we got a little bit on progression-free survival. We definitely got better tumor response rates, and it correlated with an overall survival of about 4 months. So not a huge overall survival. We got an overall survival advantage. But again, this was against old systemic chemotherapy, and systemic chemotherapy has evolved. It's really important to think about how it's evolved. We didn't throw away what we got in the beginning. We got 5-FU in the beginning, and then we added oxaliplatin, but we kept 5-FU. You probably know this as FOLFOX, or we added irinotecan. This is FOLFIRI, or sometimes we use them as a triplet therapy, so FOLFOXIRI. But we didn't ever throw away what we started with. And we're still on that very early building block with FLOXURITY. We haven't ever gone past that. And so I sort of think of them as parallels in a different universe. This is surgery world where we get to put in these pumps and treat people, but we really haven't evolved since the very beginning, unlike medical oncologists who have evolved a lot. And so, what do you get when you sort of do this? If you look at the response rate, and this is from MSK, people who've been on triplet therapy. And I started doing this, I don't know, I think I got here in 2016. So I started doing this in 2018, and I see very late stage people, who've been through a lot of stuff, and, it looks fairly similar. And so then I started thinking about how am I going to make this better? Well, one way you could think about doing this is mitigate the toxicity. And so you think about the 2 drugs that we put in the pump, and I said there's only one chemotherapy. We add dexamethasone to mitigate some of that biliary toxicity. But, I started asking questions about that biliary toxicity. It's a curious thing because there really isn't a lot of systemic therapy where you really only have one problem. In my opinion, you really only have one problem with that FLOXURITY, and that's biliary sclerosis, bile duct damage. And so if we could figure out a way to mitigate that toxicity, we may be able to give more chemotherapy. When you actually look at what happens in somebody's liver, this is sort of what looks like, this is a patient of mine. So this is somebody, if you look at the bile duct, it looks fairly normal. The epithelium is normally arranged. The structures the cells around it look good. But when you look at somebody who's had pump chemotherapy, what's happened is their bile ducts are squeezed by this deposition of fibrous material surrounding the ducts. They're squeezed shut. So something has happened, although we can't exactly appreciate what this is. And if you go back to the old literature, it would suggest this is an arterial problem. But, I don't know if I'm buying that. I'm not buying that. My job is to not buy that and try and make it better. And so I said, well, shit, how are we going to do that? You can't exactly take people's bile ducts out. It would be a little unfair. But every time we put one of these things in, we have to take out the gallbladder because the gallbladder gets this rip-roaring cholecystitis if you don't do that. And you don't have to do the operation this way, but you can dissect that cystic duct all the way down to the common bile duct. It's longer than you think if you don't really do this. And so I said, well, why don't we do that? Why don't we take that cystic duct? And I bet we could use it as a surrogate to study what happens to the common bile duct when you give FLOXURITY. And I'll show you how we did that in a second. But first, we had to know that the common bile duct was pretty similar to the cystic duct. They need to be about similar. Otherwise, we can't use it as a surrogate. So what I'm showing you is immunohistochemistry. These are some glands, peribiliary glands. And so the structures really looked more or less similar. The epithelial components are similar. The endothelial components are similar. The stroma is similar. So we thought, okay, we can probably use, and the stem cell niche is similar. This is the area where the biliary epithelium repopulates from. All of this stuff looked pretty similar between the cystic and the common bile duct. So I said, okay, we can use the cystic duct, but how are we going to do that? Okay, I got an idea. Why don't we take this system we have where we take the cystic duct, here's the gallbladder, we'll put it on these platforms, and then we'll put it in our tumor perfusion system to keep it happy outside of that person's body for a while, subject it to drugs, and let's see what happens. Let's see what cells we kill first. And so that's exactly what we did. And now this is designed for tumors that spread to the peritoneum, but I repurposed it for the purpose of keeping that cystic duct viable outside of those patients. And moreover, I will tell you that at least our thought in the beginning was, well, maybe we'll understand who's really susceptible to drug and whose bile ducts get pissed off really easily. And maybe those would be people we would never use the drug on. Now, I've since changed, I pivoted a little bit. But anyway, so this is the system. This is how we do it. So it has an oxygenator here. It has a chamber where we have these sort of chambers suspended in the patient's own plasma. So it's autologous plasma. We have a pump that circulates this. We have an oxygenator to keep good oxygen delivery. Turns out you have evaporative losses when you do this sort of thing. So your electrolytes go kind of crazy. So we add water slowly into the system. And we monitor with point of care instruments to keep everybody in physiologic range. And then when we do that, we said, all right, that's pretty cool. We're able to do that for 4 days. Let's give drug to one half of somebody's cystic duct. Let's not give drug to somebody's other half of their cystic duct. And let's see what happens. What cells are going to be really beat up by giving Floxurity? And when we did that, I'll show you what we found. We really didn't identify that it was the vascular endothelial cells, as was previously reported. And the damage marker I'm showing you is something called gamma H2AX, which is a DNA damage marker. So Floxurity is an anti-metabolite that gets incorporated into DNA, probably RNA as well, and causes damage, and that can be measured by this marker. And when you look at it overlapped with CD31, they really didn't overlap. So the cells that are damaged are not the cells that highlight as vascular cells. But what we did identify, which is unbeknownst to me, I didn't even know these glands existed, was something called peribiliary cells. And so these peribiliary glands are where all the damage occurred, and they overlap with the gamma H2AX staining, and SOX9 is the stem marker. So if you think about it, your biliary epithelium is in contact with bile, which is noxious. It's terrible. It's corrosive. And so those cells got to turn over regularly. And when they don't turn over, you have basically ulcer type physiology where the sub-epithelial layer is in contact with bile, and this probably creates a lot of problem. And so if the Floxurity is compromising the stem cells, compromising the ability to repopulate the epithelium, this is probably why you get all this damage. This made some sort of inherent sense to us. And so what we were able to show is that if you give Floxurity to these cystic ducts, you decrease the number of stem cells, you decrease the number of SOX9 positive peribiliary glands. And so we came up with this model, which we think is pretty cool because I think it's probably accurate, where you give Floxurity, and I do think some of it actually gets into the lumen of the bile duct, though I have not proven that yet. Anyways, you probably get compromised to the peribiliary glands, and that results in these you don't repopulate the epithelium properly, and that causes this inflammatory stuff, and these inflammatory cells begin to lay down matrix, and that is how these bile ducts look like they're squeezed off. And so what I thought is, well, if that's true, I wonder if we could do things to support the peribiliary glands while we're giving people Floxurity. And maybe, we could move some of these people from, they can only tolerate one dose maybe before you got to significantly dose reduce them. Maybe we could move them all back such that they would all be able to tolerate a lot more drug. It's my experience with this that those who tolerate the most drug probably do the best. And it's those people who we have to dose reduce really early on, who can't treat very much. Those people don't do as well. And we end up putting them through a lot for not a lot. So the thought is, can we move everybody back such that they could get more doses of the drug, get more drug into them? Okay, now how are we going to do that? Well, I've told you we identified the cells of interest. And because we identified the cells of interest, we know which cells are going to be important. And so I went to the people at the National Institutes for Advanced Translational Sciences, and I said, okay, here's the deal. I got this drug, Floxurity. We put it into people all the time. It damages the biliary stem cells. I want you to run a 1+ drug screen, an anti-screen for me. And I want to know which drugs that we can give that are going to mitigate the toxicity, the death, cell death, the IC50, the amount of Floxurity we need to give to kill half these cells. Oh, but by the way, it can't also prevent the efficacy on the tumor. You can't do that because that's going to be nonsensical. We would not want to do that. And so we ran this screen a couple of times, and it's super interesting. I can't share the results with you just yet because they have to be validated and we're going to publish it, but it looks like it's going to work. And the way we've subsequently proven that it's going to work is we've derived these cystic duct organoids. What is that? Well, I showed you those sort of glands that are around the cystic duct. We've actually been able to pull them out and grow them. And so the way we've been able to validate some of these screens is we grow up these cystic duct stem cells, and I'm showing you all the stem markers, and we grow them in a culture dish. And so we can take those drugs, which we said are going to be protective, and actually prove that they're able to be protective in this assay, which is super cool. So what I'm telling you is we may be able to move the therapy forward by protecting people's bile ducts, mitigating the toxicity so more people can get more drug. I think this is likely to work, but we'll see. All right, but that's not really what I titled the talk. I called it Moving Beyond Fluoxuridine. That's still fluoxuridine, but I think fluoxuridine is a good drug, just needs to work better. Okay, so then, we talked about fluoxuridine. Okay, so what about, why can't we bring any new agents to the pump? Well, you have to know a little bit about the drug itself to understand what kind of properties something has to have in order to move it forward. It has to have either a really short half-life or really high first pass extraction rate. Otherwise, you might as well give it systemic. It's not going to be any different. You need to give it to, so when you give, you all know this, when you give people fluoxuridine, I don't know if you do this yourselves, I do. When you give the fluoxuridine, people don't know it. I mean, they don't feel anything, they don't know anything, they don't feel anything. The reason is it never really leaves the liver. So it has to have one of those two properties or it's nonsensical at the start. You also need this to be stable at body temperature. Now, drugs are not designed in this way. We infuse them and that's sort of it, and they go where they go and they get, but it has to be stable at body temperature for the period of time it dwells in that, in the pump. So it's got to be, we do fluoxuridine for 2 weeks. You wouldn't do it for a day. You can't have somebody come back in every day and sort of fill their pump. So it's got to be stable and it's got to be highly soluble. The other thing, I'm sure everyone realizes this, but over a day, you only give about a 1.3 to 1.5 maybe mLs of fluid into that person's liver over a whole day. So if you can't get enough of this substance, this new drug dissolved in a solvent at a high enough solubility, you're never going to give enough drug. It's not even going to work. And then you really need to think about the target. You need probably a target that needs chronic exposure. That's the advantage of the hepatic artery infusion pump. So you think about targets that need chronic exposure, not necessarily a shock and awe campaign where you give a ton of drug at once. That would be drugs like irinotecan or oxaliplatin, these like cross-link damaging drugs. Those you need pretty high bolus type stuff. But for stuff that needs continuous exposure, that's going to be your targets of interest. And certainly you cannot have overlapping toxicity with fluoxuridine. Remember, we talked about, adding on. We're not going to replace. Remember, we didn't throw away 5-FU when we got oxaliplatin. We added them together. We didn't throw away oxaliplatin when we got irinotecan. We sort of built them all together. But it's got to have non-overlapping toxicity. If it does, this is kind of, in my mind, a non-starter. So when you look through the NCCN guidelines, which tells you the drugs that are available to treat, let's say, colon cancer or biliary tract cancers like cholangiocarcinoma, none of these are any good. None of these are going to work for you. None of these have the properties that I just talked about. And so you really are going to be left with thinking outside the box. And I first started doing this in a not direct way. I didn't start by giving something new into the hepatic artery infusion pump right away. We're going to get to that, but I started thinking, well, that's going to be, there's no drugs. What am I going to do? And I thought, well, I wonder if we could take, what does the pump do? It's like it really gives a lot of drug into the liver and gives you a really high response rate, which means you probably kill a lot of tumor cells. So I came up with this idea that, why don't we take advantage of that? And why don't we do that through this antibody drug conjugate? And this antibody drug conjugate originally was called PDS 0301. Now it's called something else, not important. But anyway, so the concept is, so I started doing hepatic artery infusion pump therapy with this antibody drug conjugate. And the way this works is patients get 2 weeks of fluoxuridine, then they come and get the antibody drug conjugate, which delivers interleukin-12 right into the tumor because it's bound to an antibody that recognizes tumor necrosis. And so it works like this. It's called PDS01 ADC. So this is an antibody. So when we kill these tumor cells with the hepatic artery infusion pump, this delivers IL-12 straight into the tumor. Now, the history of IL-12 was it worked well. It just was extremely toxic for people. But if we could get it delivered straight into the tumor, we could mitigate some of the systemic toxicity, and we could probably create some hot tumors, whereas colorectal cancer that's microsatellite stable is mostly cold. So this delivers IL-12. It's a pro-inflammatory cytokine. It induces other cytokines. It causes proliferation of NK cells and T cells, causing a lot of extra tumor cell deaths. We started doing this. And this is when before I started doing this, I started doing it just standard hepatic artery infusion pump. And this name of this trial was 18C0024. And here I just started, I've done 9 patients so far. Our response rates are better. A lot of these, I mandated biopsies early on. A lot of these people had necrosis, no tumor seen, extensive necrosis. It's early, but the results look better. So I think we're going to move this forward with this immunocytokine. I'm excited about this. It's looking good. Obviously, we need more time. I only have 20 months of follow-up, but we need more time. This is just somebody's CEA data showing the sort of stuff that happens. I had to take this person off study because they couldn't tolerate fluoxuridine anymore. You could see what happened when I did that. And then you could see the FUDR and the NHS-IL-12. That's the PDS01 ADC. This person made it to NED surgery. A number of these people have. We're pretty excited about the data so far. So I think we can move hepatic artery infusion pump forward. Again, we talked about mitigating toxicity. I'm talking about adding something else, an immunocytokine in a systemic way. But there is also a way to get new drugs into that pump. Okay, so how are we going to do that? So I told you there has to have specific sort of criteria, some certain characteristics that we'd have to know about the drugs. And I told you there's nothing that obvious for cholangiocarcinoma, nothing that's obvious for colorectal cancer. So we're going to have to think outside the box. We developed this algorithm about how we're going to do this. So you need to know certain characteristics of the drug. You need to do your own solubility testing, stability testing. We need to know about preclinical efficacy. We need to know about first pass metabolism. We need to know if it accumulates in the tumor like fluoxuridine does. And so here's the drug we thought about first using. This is called carfilzomib. Now, carfilzomib, you may say, oh, that's a stupid drug. That's used for blood cancers. Well, I would tell you that it's been tried a lot in solid tumors. The problem is you can never get it into the tumor. The half-life is way too short. And so the lack of response really is dictated by the lack of ever getting to the tumor. So when I started looking at this drug more carefully, I thought, this kind of has probably the properties you would like. And so, but it never really gets there. And so what properties does it have? It only lasts about 10 minutes in the circulation. So you think about that as opposed to if you give this systemically, it's never going to get to where you want it to be, not in any appreciable amount. So this looked pretty good. It's got a really high first pass metabolism. It is a terrible systemic drug, but it could be a very good hepatic artery infusion pump. It's soluble in D5W. We could put D5W in the pump. It doesn't appear to have any liver or hepatobiliary toxicity. And this is our stability testing. Sorry, this comes up a little blurry. You lose some drug when you keep it at body temperature for about 2 weeks, but you still get about 85% of that drug over 2 weeks. This is still a viable option for us. And you look at what's been done preclinically, with all these cell lines, it looks pretty damn good. Now you ask yourself, why is that? But it looks terrible in patients. Well, I told you about delivery. When people do these things in a dish, you add the drug in, it sits with the tumor cells, on the tumor cells. No wonder it looks so good. The problem is we got to figure out how to deliver it. And so we started doing basically these simulations outside of people using tumor organoids. So if I gave it to you systemically, you'd get about an hour exposure every 4 days. But if I gave it to you through the pump, you'd get 4 days of straight exposure. And you can see that the amount it takes to kill the cells goes way down when you do this 96-hour exposures. And so it's a much feasible, it's a workable drug at this point. Now, it's going to have to be combined with other systemic agents, which is the trick here, but I'm not going to tell you how I'm going to do that. but I still haven't told you about first pass metabolism, and I haven't told you about tumor accumulation. Those are going to be tricky things to know. So I had this idea a while ago. I'm like, well, you know what? I bet we could keep somebody's liver after resection alive outside of them for a period of time, probably a week. And so I spent a fair amount of time building this machine. And this machine, so this is somebody's segment 3 or 2, I can't remember. Anyway, so we're able to keep this stuff alive outside of people. So if I take off part of your liver for an operation, if it's the right part in the right circumstance, I will keep this alive in the lab. And then, of course, we're going to do a lot of drug testing. Well, and we can do those things I told you we need to know. We need to know about first pass. We need to know if it accumulates in the tumor. I will be able to tell you these things. We actually have run the experiments. I just don't have all the data back. Anyway, so this is what this looks like. This is a pig liver. And basically, to do this, we had to rebuild the body around this piece of liver. And so this is fairly complicated, but I'm going to walk you through it. It's got a heart, so it's got 2 pumps. You have to have an arterial pump for pulsatile flow, and you have to have a continuous portal venous flow. The saturations of oxygen have got to be different here. So you can't have 100% saturation in the portal vein. The liver does not like that. It needs to be about 70. You need, so here's your oxygenators. You also need kidneys. So we rigged up this dialysis circuit to be able to pull off some of the toxins that the liver is going to release. And that actually is really important, particularly in the early hours of doing this. And then, we have insulin and glucagon. The liver tends to liberate its glycogen stores. So you have to moderate that pretty carefully in the beginning. The liver does not like super high glucose levels, as it turns out. You need vasoactive stuff. Mostly you need arterial dilators because the artery tends to spasm early on. And then, so we have pressure and flow sensors in line. So you're able to maintain normal physiology outside of that person. Turns out you need TPN and bile salts or the liver's not that happy. So we substitute these. And then we built this, you don't need a brain, but you do, I have people that sleep next to this thing in order to maintain this all hours of the night. But in order to sort of make this a little more palatable for them, it's a semi-automated thing. So the computer system that governs everything corrects a lot of this in real time, but it still requires residents to sleep next to it. So this is sort of what this looks like. Take out a tumor, I hand it over to the people on the back table, almost like a transplant setup. They sew in the cannulas, walk it down the hall. Usually takes less than 20 minutes, usually 15 to 10 minutes or something like that. And this is sort of what it looks like while it's being perfused. It's pretty cool. This patient wanted to see her, so I walked her back down to it, showed her it. It's right here. This is her IV pulse. She wasn't quite ready to go home yet, but she was close. But this is the sort of stuff we've been able to come up with to sort of move this forward. That's my hand there. So you can see we're able to do this with pretty small segments. And so we can measure the blood going in and the blood coming out. And I know exactly the first pass metabolism of carfilzomib, and we know how much of that accumulates in the tumor and whether that's going to be enough that we know what the hepatic artery infusion pump is going to deliver. Is that going to be enough to get us, chronic inhibition of the proteasome such that it renders these cells susceptible to something else that we're about to give intravenous. What I've talked to you about today has been a lot of people's effort. I mean, over since I showed up here in 2016, so it's been a while, but it's been a lot of people that have worked on these projects. But I hope what I've showed you today is I want to move this field forward. I think it's a good option for people, but it needs to evolve and get better. And so that is my immediate purpose here at the National Cancer Institute. I will sort of stop there and take any questions. I said a lot in a short period of time. Hope I didn't bore anybody. Jenny, you would tell me the truth.
Oh, never boring. I would never use the word boring to describe it.
Well, that's probably true, but
yes, exactly. And other adjectives, not boring. All positive.
Fair.
Really interesting. Really, it's so interesting, all the work you're doing down there.
Yeah,
it must be nice to be at a place that lets you have this much creative flexibility.
Yeah, I mean, it's a different place. I mean, I tried to recruit you here, as I told you, and you would love it here. But it's a different place because, we don't bill anybody. This is not about seeing a lot of patients. It's not about doing the same thing over and over again. it's a very creative environment where it's we describe this as a high risk, high reward type scenario, where you are supposed to do things to move it forward. And, I think people care a lot less whether you write, a bunch of papers. They really care about whether you're contributing to a field. And so that's our sort of metric. And so it makes it a neat place to be and to work.
Yeah. Interesting. I see Trish is on the call. Do you have any questions, Trish?
Jonathan, it's amazing. He always amazes me that when I see that lab with the livers.
How are you, Trish?
I'm good. If oh my gosh, if we could get rid of the biliary toxicity, it would be amazing.
I got something. I got to prove it, but I got something that's cool. I actually think of all the things. I mean, that will be the immediately translatable. We could probably try it right away.
It's amazing because, we get such success with it, but that's the huge thing. You can't get enough drug into them. You always have to do the dose reductions. Amazing talk. Thank you so much.
Oh, thank you for the kind words. Hope all is well with you.
It is.
Dr. Hernandez, Juan Sanabria, thank you. This is a very refreshing talk, and I'm very glad and impressed what you're doing. I have a question. You delivered the drug intra-arterial, and yes. I was working with that many, many years ago when I was a fellow in Toronto. And again, we saw very good initial response, but we could not see an overall survival. And that was 20, 25 years ago. And that's why we led, and probably was due to toxicity indeed.
Yeah.
Now, my question relates is, what happened if you put the catheter instead of the hepatic artery to one like the middle colic and deliver the drug in the portal vein? That will decrease toxicity and deliver because this is not an ACC. This is most no arterialized tumors that are, come from the portal vein.
Yeah, so they do. So it's an interesting concept. So they do get there probably through the portal circulation, as you've outlined. But when they reach a certain size, I mean, they have to get arterial blood flow, and a lot of them have arterial blood supply. I actually thought about, I wonder if we could run two catheters, one in the artery and one in the portal circulation. I thought that might be interesting. Now, a long time ago, if you rewind the clock and look at this, you do see where people have tried to put it in the portal circulation, and it was better in the artery, so it just became what people did. But actually, I've thought about that several times, where I wonder if we could run two catheters from the pump and split it, and then run some into the portal and the rest into the artery. I don't know that, I don't know. It's the thought has crossed my mind, but people have done the portal versus sort of artery, and it appears that the artery is a better way to go. The issue, of course, is the artery is the sole blood supply to the bile ducts, which is where the toxicity comes in.
Exactly right. I'm just trying to brainstorming here. Have you tried some of the biological compounds that are coming along for like creatine kinase inhibitors through the pump? Or?
Yeah, so I think actually another really good target would be kinase inhibition. Because you think about it, if you're going to shut down a pathway with a kinase inhibitor, you really need constant shutdown. Otherwise, you're going to get these sort of on-off phenomena where you're going to get rebounds. But kinase inhibitors probably would be a very good sort of chronic inhibition type target. Now, the issue with kinase inhibitors is almost all of them are oral, and so you have to solubilize them. So we actually started working on that a little bit. There's sterility issues, but I actually think kinase inhibitors are a really good way to look at other drugs to use in the pump.
That's absolutely, you're extremely smart. That's where I come from. The creatine kinase, if it goes very slow, at very low concentration, may stick only into a tumor and not systemically, and that would be really awesome.
Yeah, I'm actively looking into this.
Hi, Dr. Hernandez. Quick question about the work on the mechanism of the bile duct injury, going back to an older drug. have you looked at mitomycin and is the biliary injury does it happen in the same manner as it does with fluoxetine?
That's a good question. It does cause biliary injury, although I've not looked at it in the lab, and so I don't know. But that you do raise an interesting point. Sometimes we do, Nancy used to do a mitomycin bolus a couple of times in the people's bile ducts. And then you look at the literature, the older literature, you increase biliary damage rates. Why that is, I have no idea, but that's a good point. But I have not looked at that drug in the lab.
Yeah, it is interesting reading through some of the older literature. The initial trials were using, nitrogen mustards with mitomycin. So it's a little hard to delineate what's causing the injury.
Yeah, yeah.
Anybody have any other questions for Dr. Hernandez? No? All right, well, this is great. Really great talk. I really appreciate you.
I guess question if I take advantage of the time. Are you implanting or treating patients with, multiple different, pathologies besides colorectal liver mets and, cholangios with the pump, or are you branching out further?
Yeah, we are. And so the immediate answer to that question is yes for adrenal. So the group I see a fair amount of that, if they get liver metastases, they do really badly and they usually die of liver disease, is this adrenal cortical carcinoma. And so the world has treated 3 people that I know of. We wrote up the first 2 with a guy called Mike Kavnar at University of Kentucky, and we've done a 3rd one. It looks like that's going to be a tumor that's going to work well. Now I'm accruing them to that study I showed you where you get that IL-12, because that is a group that does have some susceptibility to immunotherapy and checkpoint inhibitors. So I'm kind of excited to start accruing in that group. But if I'm gonna guess by your question, you want to know what other groups of patients I think could be treated, and I'll tell you the group of patients I think could be treated, but you can't do it with toxicity, is the neuroendocrine group of people. Those patients get liver metastases and they tend to die of it, but they do it over a long period of time. So you can't have a lot of biliary toxicity in that group. I don't know that fluoxetine is going to be the best drug for that because the cells replicate pretty slowly, but that's a group we're actively looking at. That's a group where kinase inhibitors really have a role there. And so if we could come up with a kinase inhibitor strategy where we could stop the cells from replicating, or at least kill the ones that were, and we could do it over long periods of time without causing a lot of toxicity, that in my mind is a very good group of people to think about.
Great, thank you.
Yeah, that's interesting because both of those groups are people that we generally use either chemo or bland embolization for their liver only disease, right?
Yeah,
It's like whack them all. So it makes sense that the pump would work in that group.
Yeah.
Find a drug.
Yeah, I think, the NET people you have to be pretty careful with because they live well for a really long time. And so whatever you do to them, you cannot cause a lot of toxicity. The adrenal cancers are pretty aggressive. And so fluoxetine, I think, works well there. I'm trying to make it work better with that antibody drug conjugate delivering IL-12 into the tumor. But the NET patients are an interesting group. And so all you have to do is keep those cells from growing and they're going to do well for a really long time. And so is there a strategy where we get this low grade inhibition where we could basically kill the proliferation? It's not very high to begin with anyway.
Right.
You can probably keep them going a long time.
Yeah, that'd be great.
Yeah.
All right, well, I think that wraps us up, but wanted to thank everybody for getting on the call. And we'll do another one in September, and look out for your abstract submission deadlines so you can all come to Miami next year.
Yeah. See you in Miami.
See you in Miami.
Thank you,
All right.
Jonathan.
Thanks,
Thank
everyone.
you. Good to see you.
Thank you.
Danny. Thank you, guys.